Okay, so well, welcome to Infectious Diseases and our guys. So Bruce has just put a symposium together, discussion together around TB after the last discussion where we do lots of things without having good reasons for them. So I was asked really just to talk a little bit about our approach to TB and just talk about how we use drugs and why, which is going to be very anecdotal rather than based on anything. But I thought I'd just give a little bit of a sort of intro to TB. So a bit of a lag. Okay. So this is a recent case that I had. I think it demonstrates quite a lot of interesting things around tuberculosis. So this is a 50-year-old female internationally competitive CrossFit athlete. And she had a year or so of interscapular pain, which she attributed to a training injury. And she went through a variety of sports physicians, biokinetics, general practitioners, and a variety of treatments. And then sort of treated this as this niggling muscle injury. And then developed 4 months of sleep disruption. And she went to she lived in Port Elizabeth, and she went to a local GP, sent on to the neurosurgeon, and he did the right things. He did a full blood count, ESR, CRP, and the ESR was 14, CRP is 1, but it persisted, so he did an MRI scan, and they saw those features on the MRI, which to a spine surgeon and a radiologist is very indicative of a discitis. And so in the context of this patient, they were thinking of pyogenic discitis, although there is some paravertebral fluid there, and he arranged a CT-guided biopsy. And they did a percutaneous biopsy, and they got a scanty Staph aureus on one culture. Everything else was negative. They sent off a TB PCR, and they got nothing else. So they treated this patient with 6 weeks of cloxacillin based on the diagnosis of staph osteomyelitis. She didn't get any better. And they repeated the MRI scan. There was some progression. You can see on the contrast view on the right, quite impressive, the uptake of contrast from the neovascularization. So they flew down, and I did a costrotransectomy cystectomy and open biopsy to get more tissue, and we diagnosed Mycobacterium TB on initially the PCR and subsequently on the culture, and we commenced RIFA-4. And she was sensitive according to the tests to all our first-line agents. So this is the lady. That's what she does. She's doing at this time. So she's quite, you can see, very fit lady. And she sent me this video to say she's doing so well after 7 months of medical treatment. But she's German, actually. And I don't know, those of you that treat German patients, they're very intense and they want follow-up MRIs and so on. So you've got a follow-up MRI. And now we had a patient that's doing headstands with the MRIs deteriorated on full dose RIFA-4. And so I chatted to Greg Simmons about this, who's helping with her, and he did rifampicin levels, and he found she had very low rifampicin levels despite adequate RIFA-4. And he made an assessment of her she being a rapid rifampicin metabolizer, and she was basically getting ineffective levels, and so he ramped up the rifampicin component of the treatment. And unfortunately, she didn't get better, and we had to go do an operation where we opened up and we actually debrided the tissue, and she subsequently got back to full sport. So it was just interesting, this case, because it's not the picture of the TB patient that we carry in our minds. And I've had a few in the years come from various levels of social strata you don't expect it in, and they often don't get diagnosed because we have our view of who gets TB, but it can affect anybody. Diagnosis can be extremely elusive. And in our country, we have to maintain a very high index of suspicion. And, so we create all these numbers about the incidence of TB, and we published this in 2019, I think it was. We worked out on a lot of assumptions on the sort of how many people are in Cape Town and so on, who really knows. That TB of the spine is about 1.6 per 100,000 population, so that we sort of worked out. And it's quite interesting. It's something we're just submitting now for publication. We took the last 100 CT-guided biopsies that were done in this hospital for suspected a lesion, and 77% came back as TB. So the thing is, if you just see a lesion, you call it TB, you're going to be right 80% of the time, which is about as sensitive as some of the tests the world has to offer. So, and it's a bit of a problem for us because it's so risky. We divide the work around lesions on the spine between neurosurgery, tumors, and infection is orthopedics. And of course, they say TB every time, and they're going to be right 80% of the time. So anyway, so it's just interesting to remember that where we work affects really how things work. And we obviously, we did, when PCRs came out, and the gene expert specifically, we had surprisingly quite a high sensitivity and specificity compared to many of the other published papers. So many papers will say in the sort of low 80s to mid 80% sensitivity and specificity. Well, this is what we found, or Michael Held, with his PhD on this, found those. I think one of the reasons is that our technique is they spin the sample that they give them down, they concentrate it where, and I think that increases your yield. And the other things, we use tissue largely. The only one of the few false negatives we had was pus, and I was told that there is an enzyme in the pus that may interfere with the working of the gene expert. So anyway, so in this hospital, we have quite a, with the methods we use, we have quite a high yield on gene expert in TB of the spine, even being mostly bacterial. But I just wanted to remind people, because a lot of emphasis gets placed on histological diagnosis and the presence of necrotizing granuloma. And again, because you're going to be right 80% of the time in TB. So this was actually a corridor consult, so typical, mothers and an orthopedic surgeon, fathers and an anesthetist, child's crying at night and from pain, can't sleep. And then the mom noticed the one shoulder's a little bit high, took an x-ray, saw this mild scoliosis. They gave me a call because I do quite a bit of scoliosis. And I just said, look, if you go to my Red Cross clinic, a child that's not sleeping at night crying, you're going to get a bone scan, you're going to get a full blood count, do any side. I mean, rather do things properly than this, because she was saying she'll come back in 6 months to see what's got worse. Well, she had a scoliosis operation. And in fact, the bone scan was hot, the ESR was 43, full blood count was normal, and they went on to do some further imaging. And this is when the DICOM started being sent around the world. We send it to every doctor in the world. So they thought this might be a Ewing sarcoma, actually. Not sure why, but I think people were thinking the worst. And we did a biopsy. I said, slow down, let's do a biopsy before we start flying the child away. And she was negative for culture sensitivity, negative for TB PCR. And the problem was there was necrotizing granuloma. And there was neutrophilia, which is obviously unusual for TB. But the whole idea was, is this TB? So then we waited for the TB culture. It was negative. We repeated it. And then I spoke to Dr. Senekal, one of the private pathologists, and he just said, neutrophilia, that's an interesting thing. Says you can get it with cat scratch disease. Does the patient have any cats? I phoned the patient and I said, do you have cats? You've got 7 cats. So then we did so I said, what does that mean? So it's not cat scratch disease. So I went and Googled 7 very old articles on cat scratch disease, and it does exist, obviously. And it's this little bug, which you can't culture because it's intracellular, apparently. And we made the diagnosis on serology and subsequent PCR. So we just have to remind ourselves, even though you're going to be right 80% of the time we say TB, just because you've got histology with necrotizing granuloma, it does not have to be TB. And so this was very close to home, this patient. So when do we operate? So we operate for a diagnosis, and it's becoming less often, to evacuate a large abscess and for neurological compromise and deformity. Now, typically in the past, we had a lot of resistance from our radiologists to do percutaneous biopsies, and the yield is very, very low. They tend to use very tiny needles. We had Zach, for briefly, he's gone to private practice, and he was using a large bore, and we definitely had a far better yield on our histology, and it became very good service. Instead of our patients lying in hospital, waiting for an hour and a half in theatre, because that's what a biopsy takes. And I know it frustrates the hell out of you guys. You can't just do the biopsy. But for us, it's like equivalent to an operation. By the time you take the patient here, put them to sleep, position them, the actual clinic cut it, put the needle in is quick, but it still takes an hour and a half of time, and it's a massive resource for us. And so we're reluctant to do it if we can avoid it. And when we had Zach here, the CT guided biopsy system was working very well. It seems to have fallen off a little bit again, and hopefully we can get that moving. But this is an example of the patient was sent to me as TB at that stage, and maybe you guys know it, but I didn't know this genetic condition of chronic granulomatous disease associated with certain bugs, but this was sent to me by a rheumatologist, and this must be TB. Why don't you please do a angiocorpectomy, remove that C7 and reconstruct? And I said, no, let's do a biopsy, and it came back at aspergillosis. And if you understand the underlying condition, you will expect that now. And as you can see, 6 weeks of a voriconazole totally resolved. So the patient didn't need, in fact, if it was a CT guide, it would have had no procedure. This is a 13-year-old child. You can see the very large psoas abscess. These children usually children come in with severely flexed hips, unable to walk, can be misdiagnosed as a hip septic arthritis. And to my mind, the penetration of that abscess is just going to take so long to resolve. It will, but it takes so long. And we do a simple operation, release that pus, get all the tissue for results, and within a day, the child's walking. So that'd be an idea where we would operate simple operation. Neurological deficits, we operate generally, except if anybody's deteriorating dramatically neurologically, we intervene. Those that come in, like we get many patients referred to us as Frankel Bs and Cs, off their feet for some time. We know from the very old Hong Kong studies that medical care is as good as surgical care in terms of neurological outcome. Our experience, and it's not well published, but it's general surgical father to son experience, is that they recover quicker if they're going to recover with surgical decompression, especially if there's bony compression, it's not going to resolve medically, so I would remove it. But if there's pus, they seem to get better quicker. And our pressure on beds to get people out of here, and the often poor nursing care that leads to the complications of recumbency with paralysis. So we tend to operate with neurological deficit if the patient is otherwise capable of undergoing the procedure. And then lastly is deformity. So there is evidence to predict deformity based on the amount of vertebrae destroyed. So if you treat somebody non-operatively, your 5-year kyphosis is related to the amount of destruction in terms of the bodies of vertebrae. And the question is how much kyphosis is tolerable. If you look at it, we're all trying to avoid late onset paraplegia, which is not due to the actually acute disease, but kyphosis with an internal nubbin and the spinal cord rubbing on that and causing late onset gliosis and irreversible paraplegia, as opposed to the reversible one that you get when it's acute disease. You tend to have to get pretty big curves. If you look at the studies that looked at the paraplegia like that, they tend to be around 100-degree kyphosis. That's quite big. When I worked in Europe, in the UK, they would often operate for a 30-degree kyphosis. I think, we work on about 60. More than 60 is probably unacceptable. But, because it's all risk-benefit. And then, how do we do it? You just have to remember where we're working and who's doing it. I just want to show a video clip so the non-surgeons get an idea of why we use the drugs we use as a small little defense. But this is a typical thing of cervical disease. You can see there, a very simple operation by our standards, do through the neck, remove the bone, put some ileocrestin and plate it, and the patient's happy forever. So this would be our more typical thoracic. We always say it's more common in thoracic, but if you do mass, it's 12 thoracic versus 5 lumbar versus 7 cervical, so it's more likely it's going to be thoracic just on numbers. But that'd be typical of TB, and just for the experienced X-ray people, when you see this, always look at the posterior elements, and immediately you can identify there's 2 vertebral bodies there. It's not just a wedged single vertebra. But this is a video I want to show Marc. So the main thing here is a video thoracotomy just too. But what I want to show you is what the abscess looks like, because one of the reasons we think we require drugs for longer time and multiple drugs is that the penetration of the abscess is not as good as as in the lung, and lungs well vascularized and so on. So when we do this sort of work, we open the chest, and you see this is the abscess here, and the aorta would be over here, and we just expose it, and I'm going to incise it so you can just see it. Zoom just slows it down a little bit. So there's the easy pus, and we always take a sample of the pus, we send that off for Robin's PhD. And then this is the case here. This is what caseation looks like to the eye. And you see how not avascular it is. It doesn't really bleed. And you just wonder how well those drugs are getting into it anyway. Then we do the rest of the orthopedic bits. So that's really, I just wanted to give you an idea of what we faced with in there, and to give you. And then sometimes we get more complicated things like a 4-year-old child with multiple vertebral involvement, myelopathy from compression. And here we may do traction for a while. We'd operate. We may use a halo. Sometimes we put screws, small screws, and so on. So it can get a bit more complex. And more now we do the surgery all from behind, where I'm not going to go through each video, but we expose the cord from behind. We sacrifice some of the nerves and reconstruct. We do a circumferential. We believe we want to get all that pressure off the spinal cord, debulk the caseous tissue as much as possible, and then reconstruct with the tools that we have at our disposal. Then we can get that sort of thing. So just this picture, sorry, this is lag. So using that circumferential decompression, you can see we get quite good neurological recovery. So of our Frankel C, so that would be sensation, tact, useless motor. All our patients became ambulatory. 6 normal, 3 had slight motor weakness. Of those that could walk, we had 1 catastrophic child came back from home. Instrumentation failed and became paralyzed, but we generally maintain it. And all those that were normal stayed normal using the circumferential technique. And sort of one of my papers many years ago, we just looked at outcome of all comers, all the adults, in terms of what we did. And then the blue shows preoperative and the red is post in terms of the Frankel scoring. And I remember these papers used to get rejected by the international literature because they would tell us that Frankel A's, in other words, no motor, no sensation, do not recover, because people are used to trauma where there's much more energy dissipation during these injuries, and they're very unlikely to recover. But you can see the vast majority of our Frankel A's do recover. You can see the shift of the red towards full neurological function. So that's what makes TB a very pleasant condition to treat, because you get good outcomes. So problems are your quality, your patients, your host status, which is often a difficult thing. And if you look at the softer items like emotional and general health status, energy levels, pain, so on, these lines show how they improve. As you get to the periphery, it's better, and each one's a different number of weeks. So you can just see the physical takes quite long to get there, whereas actually the emotional side of things, they're quite happy they get treated, so they score quicker. Just to show the orthopedic surgeons the feelings too. And so then there's the crutch slide over here. So what duration? So I think we were hammered a little bit last time, like, why do we use 9 months? Now, I wrote some papers years ago on medical management, and I researched what other spine surgeons were doing. And I mean, in India, they're still using 10 months. UKZN, they're still using 18 months. And there's no strong reason for this. We all used to use 18 months. And in the early 2000s, when HIV was new to us, we differentiate 18 months for HIV positive and 9 for non. We've settled on 9. We used to be 12. When I came through as a registrar, we were 12 months here. Why I think we changed is in those days the daily observed therapy was 5 days on, 2 days off, because the clinics were shut over the weekend. Then we got to a continuous situation. So we felt we could shorten. It was a little bit shorten, let's see. And we monitor our patients. So the way we manage these patients, we do whatever we do, and then we see them at 3 months, 6 months, 9 months. So we can follow them clinically. Are they gaining weight? Are they feeling energy? Their levels getting better? Is their x-rays looking better? And their neurology incoming? And if that's all happening, we'll stop at 9 months. If there's any concern, we will go on for 12. Now, it's purely, we wait to be enlightened, but that's been our approach. Why do we go long? My concern is about recurrence. Yes, we might get really control right in the beginning, but we've been taught that there's an intracellular, slow, metabolic mycobacterium sitting in that macrophage. We kill the easy ones, but we've got these little lurkers. And our concern is the lurkers come back. They're in areas that we may not get good penetration of the antibiotics. We know on post-op MRIs or even follow-up MRIs, we get these persistent collection of fluids, which we're told are sterile, but how sterile are they? So that would be the reason that we're still using 9. I know the province came out some years ago and they just said all extrapulmonary TB is 6-month therapy, 2 months of 4 drugs and 4 months of continuation phase. Anecdotally, the patients that have come back with recurrent disease or persistent disease have been the ones that get dropped to the 2 drugs. Now, look, you see what you look for, don't you? But, that's been our case. And we, as Mauritius, when I was chatting to him about it, we're never quite sure how many patients are dropped to 2 drugs, because they may be successfully treated on the 2 drugs. But the ones that come back to us and we have problems with, which often have comorbidities and other diseases, associated diseases, HIV and so on, because 50% of our patients have HIV in this group. Seem to be the ones that have been dropped to Rifina. So that's our reluctance to change. So our current protocol is Rif for 9 months, with a possible extension for 3. But I'm open to hear what you guys have to say. Thanks very much. Robin's coming to talk to us. Yeah. We don't need my computer anymore. Sharing. That's yours, eh?
Yes. Thank you. Good afternoon, everyone, and thank you very much for the opportunity to provide an update of my PhD project. For those of you who may not know me or may not be familiar with my work, I am a PhD student in the Orthopedic Research Unit in collaboration with Sidri Africa over at Health Science. And my research focuses on exploring the use of novel diagnostic tools for improving the detection of spinal tuberculosis, and also understanding the immunohistologic effects of both TB and HIV, especially in our co-infected patients in bone and related tissues. Just a short agenda. I will aim to give a short project overview. I will give an update on my current patient cohort characteristics, as well as some preliminary diagnostic data. And then I will introduce those who don't know about the world of droplet digital PCR, one of my really sensitive diagnostic tools that I'll be using, just highlighting some future work and obviously thanking everyone who's been constantly involved in the project itself. So we are currently recruiting hospital-admitted adult patients who are presenting with signs and symptoms suggestive of spinal TB. With the help of the spine team, as well as our research nurses, we are able to identify and recruit consent patients. A lot of information all the way from HIV investigations, TB, to socio-demographic and socioeconomic questions are asked, and this is all captured by myself on a REDCap customized database. We collect samples both pre and during surgery. The samples of whole blood and urine are collected pre-surgery, and during biopsy, thanks to the surgeons, I'm able to collect both pus samples and tissue samples. And ultimately, this feeds into the laboratory analyses, where we're really interested in looking at diagnostic protocols, as well as more exploratory-based laboratory procedures to investigate just how the spine TB is manifesting and how its immunopathology is undergoing. So just to highlight how these biological samples are processed for both the diagnostic procedures and the more immunology-based exploratory investigations. The spinal biopsy tissue is excised either during open surgery or CT-guided biopsy. That is processed according to GeneXpert Ultra, which we are doing versus gold standard midget culturing. And then in addition, in my laboratory, I am optimizing experiments on a droplet digital PCR, which is very similar. I'll dive into this, but it's very similar to the GeneXpert Ultra in trying to pick up the presence of TB. And this is based on an optimized protocol with one of our collaborators, Dr. Adrian Martineau, who is looking really interestingly into whole blood samples to find latently infected TB patients. The urine is currently being stored as both neat and filtered aliquots, and my hope is to, once they currently are stored, supply issues, of the Fuji lab, we're hoping to do a rapid point of care test to pick up lipido-arabinomannan, especially in our really sick HIV positive, TB positive patients. I'm also collecting whole blood. The sodium heparin green cap tube, I'm isolating plasma from that, which will ultimately be, at the beginning of next year, be taken forward for biomarker profiling using a platform called Luminex, which is really incredible in that it can simultaneously detect a whole host of really interesting proteins, cytokines, chemokines, and growth factors. And that will allow me to look at TB markers, HIV markers, and really interestingly, bone markers. And then in addition, we're collecting Tempest tubes there, the blue caps, which in the future, we currently biobanking those, but in the future for gene expression analysis in our patients, which might reveal some really interesting results. So this PhD is allowing me to undertake really vital work. And I think I've just put the schematic here to show you how many elements it has and how I'm really lucky and fortunate to have a diverse team of immunologists, orthopedic surgeons, infectious disease clinicians, and nurses who are helping me understand the clinical environment. With patient recruitment, I'm able to see the patient, and I'm able to then take forward their samples to ultimately see where these samples are coming from. That's all obviously fed into my database, which hopefully can be a groundwork for future databases. The laboratory analyses, of course, the molecular mechanisms, really diving into what's happening, especially in co-infected patients, the data analysis, and then hopefully feeding that back into the system to guide some more clinical-based approaches. So a busy slide, but just one to highlight that I've successfully recruited 29 patients, and this obviously has been since COVID. We've lifted the suspension on all research activities since last year, November, 13 of whom have undergone CT-guided biopsy and 15 with open surgery. And I've just split them I've taken the liberty of, at the moment, splitting them according to diagnostic criteria. So I've got definite spinal TB, 6 patients, that's culture positive and gene expert positive. Probable TB, I've got 31% of my patients, either culture positive or gene expert negative. Not spinal TB, I've got a couple of patients who are coming in with E. coli being picked up and general more cancerous tumors. And then I've just got 3 patients who are currently unknown, either culture incubating or samples were actually lost along the way. And this table also just highlights some of the cohort characteristics. We've got a 59% females. I know we often see a lot more males. The age, around 48, we've got in the definite TB section, we've got younger patients, 34 years old. We've got an almost even split between our positive and negative patients. And I'm glad to report that everyone is on antiretrovirals. Some we have flagged because I have such access to the rich history of the medical history of these patients. I can see how their CD4 cells and how their HIV diagnosis is changing over time. Some of our patients have really low, the most recent ones have really low CD4 cell counts and detectable viral loads. Some are incredibly high, and we've actually flagged them to the team who've involved social work. Symptoms, we've got a couple of patients coming in with cough. Those are pulmonary TB patients as well. Weight loss in a lot of patients, and I know in previous research that is one of the constitutional symptoms that accompanies spine TB. And night sweats is seen in quite a few patients, but I know also from previous papers this might be ascribed to other ailments. And then my blood results, just to note, my red blood cells in most of my patients are quite low, and my hemoglobin as well. And then of course our really important inflammatory markers are both ESR and CRP are raised in all of my patients. And just to note, otherwise specified due to unavailability of some of the diagnostic values, I just work with how many patients I have those values for. Just some preliminary diagnostic results. I've split this according to my positivity of Gene Expert Ultra. I've got 6 patients who are both positive on culture and Gene Expert Ultra, 7 who are positive, negative culture, and the rest is ongoing. And then quite interestingly, it might be self-explanatory for some, but quite interestingly for me on the right, I've indicated the CT values that I'm given with the Gene Expert Ultra. And what's interesting to note, in my dual positive patients, they have a lower CT value, which means obviously they've got a higher bacterial burden. So it's ultimately the Gene Expert Ultra is able to pick that up really quickly. And then in my culture negative patients, it takes a little bit longer to pick up the bug. And just overall, I think Prof. Dunn was speaking a bit about histology. In 8 of my patients, we are looking at necrotizing granulomatous inflammation, and that goes all the way down to just general degenerative changes. I've had a patient who's had a metastatic carcinoma, and then 6 of my patients is consistent with mycobacterial infection, and often that's if the culture's negative and the Gene Expert Ultra is positive. So it's indicative and it's treated as such. So just to dive into, to highlight one of the main laboratory assays that I'm going to be focusing on as an additional diagnostic tool is the world of droplet digital PCR. And I'm not sure, for those who may not know, I just thought I'd just give a bit of a schematic. But very similarly to Gene Expert Ultra, which picks up the presence of TB DNA, droplet digital PCR, we've got an optimized method of also picking up TB DNA, which is an incredibly sensitive and precise method. And what digital PCR does is it actually, in your sample, it divides your sample into 20,000 or so droplets. And within each of those droplets, there's some templates. And the aim is to actually pick up individually within each of those droplets and understand the presence or absence of TB. And they make use of, I've added on the side there, they make use of probes, which are almost like molecular beacons, which light up once you have the detection of the bug. And I will, so what's really, really important about droplet digital PCR and why it's a lot up and coming in TB is that it's able to quantify really low abundant targets. And that's what we often see in our spine TB patients because of the nature, the coarse bacillary nature of our patients. They might not even be the bug there, but the residual DNA might be there. And as I mentioned, the gold standard has always been culture. Its disadvantage is that it's lengthy, but ddPCR offers an unparalleled sensitivity, really, really high precision and absolute quantification without the need for a standard curve. And I've added there, but good DNA extraction precedes this. So this is what I've been really busy with in the laboratory recently, is being able to actually extract good quality DNA from my tissues and take that through the system to try see if it's a lot more sensitive at picking up the bug in the cases where I'm not picking them up via NHLS. Just to note, the main limitation here is that it is quite a costly procedure, and it does take a lot of really highly skilled laboratory personnel to be able to go forward with this. And I mentioned Dr. Adrian Martini earlier in the presentation, but just to highlight some of the work that he's doing, which our work is based on, he's been able to successfully pick up TB DNA in whole blood, in stem cells of asymptomatic patients living in high TB areas. And the clinical relevance of this is that he's picking up a novel microbiological biomarker of latent TB infection, implicating the bone marrow as a niche for TB in latently infected individuals. And just to highlight briefly that he was able to detect this more commonly in the stem cells that he was looking in, and that HIV actually, he's looking more into how HIV actually impacts the detection of this, of TB. And he found that both in HIV infected participants, you could actually detect much higher copy numbers of both, in both of these types of cells. So just an overview of maybe for those who wouldn't know what I'm busy with in the lab, but this is what I have to do before actually plugging it into the system. So I'm processing these biopsy samples for this experiment that I just want to run through the next few results for. Is I've taken 2 gene-inspert ultra-negative patients and I've ground that sample up, and what I've done is I've mimicked a scenario where I've spiked TB into these tubes, and I've obviously had to heat kill that for biohazardous containment. And then I've ultimately compared 2 methods of extraction, and you'll see that it says CTAB there on the side, and that's really, really important with breaking open the really tough cell wall of TB to be able to actually extract DNA and ultimately pick it up. So just the tubes for extraction on the right there that I had was I spiked and heat killed where I'm expecting to pick up DNA, and on the right was tissue ground, as is where I'm not expecting to pick up anything. And this actually generated yesterday, and I'm really new with this, so I'm really excited to generate some more data and to show everyone. But just to highlight that we're using 2 molecular probes, those beacons that fluoresce really nicely. Channel 1 is a specific type of beacon, and channel 2 is another beacon. In this case, we are using a gene called RPP30, which is present in human DNA. So using this droplet digital PCR, you can see the green droplets at the bottom are positive reactions. It means the template was successfully picked up, whereas the line below the pink threshold is negative, means those templates didn't have any template in, those droplets didn't have any template in it. So this just shows that successfully, I was able to successfully extract genomic DNA from my tissue ground up. And the next two slides are just showing that I was able to successfully detect the genomic DNA that I had spiked in. So I was able to break apart the actual bug itself, get out the DNA, and it's successfully and sensitively picking up a range. So at the top is RPOB, which is a single copy that's rifampicin resistance. That gene can be changed for rifampicin resistance. And at the bottom is IS6110, which is also used in the GeneXpert Ultra. It is a multi-copy gene within TB. So it's successfully showing in the first three that it's picking up the bug, which is great, that everything's working. In the fourth column, A3, that we're not expecting to see anything there, so that's great. And then we've obviously had to include a positive control and a no template control. So I won't go through this, but exactly the same, just the two types of methods. So going forward, I need to trial DNA extraction and droplet digital PCR from my positive GeneXpert Ultra and culture positive patients and run this to a really low level of DNA to see if I can detect it. And that's quite interesting because I might have a patient who is culture negative, GeneXpert Ultra negative, but we may be able to actually pick it up with this really highly sensitive droplet digital PCR method. So that'll be interesting to relay those results. And then, as I mentioned, the Luminex runs, I will get a really rich data set in January and February once the kits arrive, in relaying information of TB, HIV, and be able to stratify that according to my HIV positive, COVID now positive patients as well. And then ideally test both the neat and filtered urine samples using these these point of care tests. And the aim remains to submit my PhD thesis by December 2022, which is next year already. And thank you, I think, to everyone here who's also been really heavily involved in my project and who will continue to be. So my thanks and gratitude to you all, and of course my PhD supervisor, Prof. Michael Holt, who's not here at the moment, Anna, who's overseas, and yeah, there's an enormous list of people who are really helpful. So thank you, and if anyone has questions, I'm happy to answer to the best of my ability. Sure.
Robin, great, fantastic, really nice work. Thank you very much. A couple of comments. I mean, your diagnosis, your categories of probable versus definite. I mean, probable, you're including patients that are culture positive, which is the current gold standard. So, I mean, how genuine is that distinction between these two groups, definite and probable? I mean, I appreciate you're getting getting a disconnect between the tests you're seeing probable, but actually
it might.
They're one group. Because I would say culture positive is a definite.
100%. Thank you. That it's for me. I just initially took the liberty of this, but I'm learning as I go. So obviously, what is the gold standard? But that's very beneficial to obviously just include the culture positive in the definite.
Well, I just think you're going to be trying to find between the two groups, which actually, more importantly, is defining those that really are probable TB that maybe clinically or radiologically, we've heard that difficulty is to separate whether an HIV patient is constitutional symptoms plus, and it's more likely. Anyway, that's saying that, the other question, two other quick points. The CT values you showed, there's quite a lot of confidence interval overlap. So I'm not convinced from what you've shown us so far that there's any difference between the two in reality. And then staying on the CT threshold, for the digital drop PCR, what CTs are you getting? Because you're suggesting that it's going to be more sensitive.
So thank you. So what I'm going to do in the next week is actually do the droplet digital PCR on my positive samples and then be able to compare that to the CT value I've been getting in GeneXpert Ultra. So I'll definitely let you know because obviously this data is really fresh and I'm learning how to analyze. So I'll definitely let you know how it compares to what I'm picking up in the GeneXpert Ultra, what actual CT, what CFUs I'm actually ultimately being able to detect.
Well, the last question is, when you're going to be doing your Luminex, and you're going to be making a comparison between TB, non-TB, and a positive control, is that correct?
Correct. And
because so far you're using H37RP, which is a laboratory strain which has a lot of deletions out of important clinical value in clinical strains. So you're going to be using clinical strains or H37RP.
That's a great point. Something we haven't discussed at the moment, but I think that's a really great point. And it's something that I was actually thinking of earlier in understanding how many, obviously, my patients will have lots of different kinds of strains. And how do I account for that if I'm just using a laboratory strain that I know? So that's a really good point. Now, I
mean, it's been, you know,
thank you.
Anyone who's worked in the lab with H37RP and trying to correlate them with clinical, in clinical wise, it runs into the same problem. And just to comment, the last thing, just to say that again, there's this issue about the use of ESR in HIV patients. So HIV patients have, as you know, hyper stimulation of the B cells, and ESRs, we take 100 HIV asymptomatic patients, the ESRs can be raised in a large majority. So it's not a good test in HIV. If really we don't do it, we really suggest that people don't do and don't follow it. Because again, it can lead you into problems clinically if you're following up somebody with an ESR and HIV, and if it doesn't come back to normal.
Thank you.
Just to
that's great.
Clinical.
And I think that's also why I'm this.
Now the real expert.
Yes.
I'm going to ask very similar questions. Thanks. It's great to see that you're making progress. Really nice to see. Yeah, just to come back to these clinical categories that you've created, seemingly kind of arbitrarily. I mean, I think it's really important, especially if you're going to analyze them down the line, to define them a priori. So, you know, whatever you do, you know, just make a decision, define them, and write that down. Because otherwise, you know, there can be severe bias in analyses that you do. And then a question about the digital droplet PCR. What is the purpose of doing this? I mean, how are you going to analyze it? What is the ultimate aim? Do you just want to optimize an assay? Because I mean, the diagnostic performance of Expert Ultra, as we heard earlier, is outstanding. And that's a commercially available test. You can do it in minutes, and anyone can do it. So, I mean, do you see that the ddPCR is going to be a future diagnostic? It's invasive anyway, you need a sample.
Yeah.
Or are you planning to use it as some sort of biomarker? I mean, what's the objective for that?
It's a great question. Thank you. And it was something that I was discussing with my supervisor yesterday. Even with the complex, we were trying to figure out how much it costs per reaction, which is way out. So it's obviously droplet digital PCR isn't only to detect the bug itself. I mean, it's really interesting to see if the method that Adrian has optimized is working in tissues as well, because obviously he's managing to do this in blood. So I think it's the more exploratory understanding and how low we can detect to, because I know obviously for GeneXpert Ultra, sometimes with droplet digital PCR, you can actually detect even lower than the Expert Ultra is able to even detect. But I think it's clinical translation. I mean, I know it's being used in certain laboratories, but it's more for research than it is actually for.
I think you should define how you want to do it. And it comes back again to the clinical categories.
Yeah.
Because I mean, I'm interested in those patients that are expert negative, culture negative, but still actually have TB.
Yeah.
I mean, that's the group that we're interested in, because the expert, it's easy to diagnose them by.
Yeah.
So I mean, just going back to your data, I mean, you showed a table earlier with the histological findings. And it wasn't clear what the denominator for that was. Was that just the group that had probable or definite TB, or was it the whole cohort? And out of those that had probable or definite TB, it's very interesting. I'd be interested now to know what's the histological spectrum was.
That's absolutely, and that's, yeah, I was so excited to, I was actually had a couple more slides on my computer, but of trying to split it between those groups. But now I think that I know that I need to get these definite categories, and stick with those, then I can fit all my data into those and stratify according to those groups as well as HIV status. It's a great point. Thank you.
I think you'd be very, very hard pushed to convince anybody where you've got a culture positive
Yeah.
that it's not TB.
Yeah.
Check that's problem.
Yeah, so I mean, it's really a question of, but as Rob, as you showed that, that granulomatous reaction, that wasn't TB. I mean, it's clear that histology is it's only part of the issue. The other thing is just when you were saying about Adrian trying to be interested in what the ddPCR does in blood, in tissue.
Yeah.
But you've got blood contamination in your tissue. So it's very difficult to, unless you are able to put a molecular beacon marker up to a host, or a specific blood cell type, or a specific synovial type, or whatever you're doing is going to be almost impossible.
Absolutely, and I think also future work is really interesting to, we're thinking of teasing out specific bone cells and looking if, TB is hiding in there. That's the ultimate really interesting exploratory work. Where's TB hiding? Is HIV hiding with it? And what types of cells is it hiding in? So that's really...
Well, in those samples, you've probably got CD24 myeloid progenitors.
So I can pull those out, yeah.
Not just in the blood, which is what Adrian was looking at.
100%. Thank you.
Really interesting, but
Anyone else, just ask you one other thing. Have you considered doing any PK analyses? These tissues, I mean, these samples are precious. I mean, we've heard about, we'll probably talk about this a little bit later, but we've heard about some of the gaps in knowledge about drug penetration into TB lesions in bone. And I mean, you've got an opportunity here to study this, and assays could be developed. I know that our lab could develop assays to look at drug concentrations in these samples.
Yeah.
And it's just a suggestion for someone to consider.
We started that process actually with the lab, and they lost interest. They said that they needed us to develop whatever the tests are on the rest. And then they just died. So we really contacted them. Because that's the big question. I mean, there are Chinese papers where they've shown, the or not. I mean, there's a paper, I forget his name, but they were promoting a 4.5 months treatment based on the penetration. But yeah, I don't know. I mean, I don't know where we would go. I thought it was a matter of just sending a sample off and you got an answer. But apparently there's a process that has to be developed.
I mean, let me know, and I mean, we can try and reopen those discussions, because I think that's a fascinating aspect to this. Yeah.
Thank you very much.
Afternoon, everyone. For those that don't know me, I'm Tari. I'm one of the infectious disease fellows at UCT, and today I'm going to be taking you basically through the evidence for the treatment regimen as well as the duration of treatment for spinal TB. Okay, so let's go through. Okay, so we're going to go through bactericidal versus sterilization TB. I just want to give you some definitions so you can understand the basis towards the talk. So bactericidal is basically the rapid clearance of these extracellular metabolically active bacteria. And there's something called EBA, so it's early bactericidal activity, and essentially it's a fall in the log of the colony forming units of MTB per ml per day for the first 2 days of treatment. Okay, and then sterilization is essentially targeting the metabolically dormant or the semi-dormant bacilli, as well as those other bacilli that may be in sanctuary sites. And one can think of intracellular bacilli being part of this metabolically dormant population. Okay, and then this is just a table basically showing how the drugs work. I think the core towards understanding what regimen to give is to understand what each drug does on an individual level. So as I said, early bactericidal, first 2 days, and as you can see, rifampicint's got pretty good, intermediate, but very good for sterilization, actually the best one. INH, and you'll see a little bit later, actually is the highest for EDA and intermediate effect on sterilization. PZA, pyrazinamide, not the greatest there, but for sterilization, it's a good drug. And then ethambutol is intermediate to high, but with regards to sterilization, not a great drug. Okay, and then this is basically just showing what I've explained. This is EDA with regards to the first 2 days of therapy. And as you can see over there, isoniazid has the biggest effect on the bacterial populations, followed by PAS and ethambutol. PAS, we don't really use so much nowadays. There is data to support that it's not as good as other drugs. And then, I mean, it does have quite a side effect profile as well, including diarrhea. I've only probably prescribed it once or twice in like 2 years here. Not a commonly used drug. We usually use it for our drug-resistant TB populations. And then rifampicin, great drug. Streptomycin, not bad, but we've moved away from the aminoglycosides, a lot of ototoxicity and, as you guys all know, nephrotoxicity, so not a drug we go to. And then there's pyrazinamide. This other drug here we don't even bother with. I haven't. This is the first time I ever learned about this drug, was now. And then, so let's look at the bactericidal killing. INH, isoniazid, as I said, first 2 days really drops your load. Rifampicin killing in the first 2 to 7 days, and then PZA is basically 14 to 28 days. And I put this graph over here to show the log colony forming units over there and then the days of treatment. And as you can see, this is a very old study, 1956. And the HZ regimen, so that's isoniazid and PZA, dropped your bacterial bacilli load very significantly, up to 60 days, whereas SPH, that's streptomycin, PAS, and INH, you can see it's a lot slower. So hence we don't use streptomycin or PAS as much. Okay, so I'm sorry to bore you, but it does make a difference about understanding why PZA is given for its duration of treatment. So essentially, what does PZA do? It as we alluded to earlier, it goes for the metabolically active TB bacilli and looks at the extracellular matrix bacilli. So that's basically, it's the bacteria that are sitting in the cavity. So if you can think of a pulmonary TB, you can imagine the cavity. The bacilli mainly sit in that area over there, but has got not much activity against intracellular bacilli, but that is a little bit of a controversial point. Some people say, no, it does, and some will say, no, it doesn't. And the way that PZA works is that there's your PZA, it's actually the prodrug, so it needs to diffuse across into the MTB, and then it's changed into pyrazonic acid, and that has to change. That reaction happens because of acid production that happens within the bacteria, and the metabolically active bacteria are the ones that are going to produce lactic acid, and then the acid then changes to pyrazonic acid, and that's how basically it's able to kill the bacterium. And importantly, it's also very important that you note that it should be combined with rifampicin for its effects to be even greater. Okay, and then once again, a very old study, but this is short course chemotherapy done in Hong Kong. And I specifically tried to show PZA and why it's used for 2 months rather than 4 months rather than 6 months. And as you can see here, what they've done in this regimen is streptomycin, isoniazid, rifampicin, and PZA. This is the 3 illustrates 3 times a week. And they gave PZA for 2 months, then 4 months, then 6 months. And they gave for 6 months the regimen in total. And the relapse rate at 2 years, as you can see, is pretty similar between the different regimens. So in other words, you can say to yourself, well, PZA after 2 months, yeah, probably not that effective. And then what is the clinical implication? So back in the day, they would probably, well, back in the day when we didn't have TB treatment, there was nothing. Go to the sanatorium and breathe in some fresh air, or go to the top of the mountain. But now PZA is come onto the, well, is now one of the great drugs that we have in TB, and basically our regimen has gone from 12 months to 9 months, and now we're sitting at 6 months. But as I already said before, it must preferably be combined with rifampicin. And also there's data to show that the relapse rates when PZA is added into the regimens is much less. So for example, when we have our DILIs, our drug-induced liver injury patients, if the PZA is the culprit, we actually extend our treatment duration from normal 6 months to a 9 months regimen because of the fact that the PZA is lost. Okay, so let's look at ethambutol. Same slide that I showed you earlier, just with ethambutol. As I said, EVA is intermediate to high, and sterilization is not great. So then you're going to say, hang on, why are we even bothering with this drug if hasn't got much utility with regards to sterilization? And it is actually a pretty good drug to still give, because as you all know, in HIV, we always punt, patient must get triple therapy. Well, not in every case, but in most cases, we'll say patients must be on 3 ARVs, and that's to make sure that you decrease the likelihood of developing resistance. So what I'm saying is, for example, you might have this MTD bacillus over here, which is rifampicin resistant, but is PZA sensitive. So you can imagine if you've got PZA, it will take care of that population. So it decreases your risk of developing resistance when you've got a lot of drugs on board. And obviously we know there's an increased success in patients that have been that get ethambutol for sensitive TB. And then you might say, but hang on, so why aren't we just continuing it for 6 months then if we still see that there's a utility towards giving patients the drug in the four drugs in the first 2 months? Well, the reason being is that by the end of 2 months, your bacillary load is exceptionally small, to the extent that you could just still go on to your rifampicin and isoniazid to take care of those other intracellular bacteria that you might not get to. And also by that stage, your resistant mutants are probably not there anymore. Well, at least you hope that is the case. And this was a really nice article that Prof Osserman sent me, and if anyone has the time, it's 51 pages, but sure, it's a really nice read. I haven't read all of it, I can tell you that much, but it really goes into the history of TB for the people that are interested. Okay, so Prof Dunn, I think this is the article you were talking about. Yeah. So this is an article done by Guy, apologies to him if I'm saying it wrong, but basically measures the concentration of 3 anti-TB drugs in spinal tuberculosis. And it was quite a cool study because they actually only gave treatment for 4.5 months. And importantly, it's to note is that every patient out of all 24 patients had surgery done at 4 weeks after starting TB treatment. And what they did is they took samples from the bone to check what the drug concentrations were of the various drugs. And the intensive phase was 2 months of RAZE, so that's our Rifa-4, plus streptomycin. And then they went on to a continuation phase of 2.5 months with twice weekly rifampicin, isoniazid, and PZA. Okay, so we can now look at the bone penetration of the drug. So the way they divided it was dependent on if it was sclerotic bone or if it was non-sclerotic bone. Okay, so this is the serum concentration of the drugs, of the rifampicin, the isoniazid, and the PZA. And then this is in normal bony tissue, so in the ileum. And then subnormal bone was essentially the pathological bone, so the TB, the vertebra that's infected with TB. And as you can see, actually the drug concentrations between the ileum and the subnormal bone are actually relatively the same. But if you look at sclerotic wall of the vertebra, you can see drug penetration is really not good. So in this study, their feeling was that surgeries would be of utility for these patients to try and get rid of the sclerotic wall, to try and allow the drugs to penetrate. Okay, now let's go on to, so that's the drugs we've discussed, and then let's go on to duration of treatment. Unfortunately, there's not a lot of data surrounding that. We'll go into that now. But each society has their own recommendations. But if you follow IDSA, Infectious Disease Society of America, or ATS, American Thoracic Society, in the CDC, they recommend 6 to 9 months, but experts favor 9 months because it's difficult to assess the response to treatment. And in patients that have orthopedic hardware, they suggest 12 months, but all of this is based on expert opinion. And then WHO says 9 months. And then you look at the NICE guidelines from the UK, and they say, well, if there's no CNS involvement, then you can consider 6 months of treatment. But if there's CNS involvement or coexisting HIV, then it's 9 months of treatment. Okay, and then let's go back to this Fox article and then look at the treatment of spinal tuberculosis. We've gone from 1965 to, if I'm not mistaken, this was 1993. So there's quite a lot of studies being done, and it's also in multiple different countries, Bulawayo, yes, Africa for us. Problem is to try and read into this data is difficult, and that is because of the heterogeneity of the studies and comparisons. So, for example, the Korean paper gave 3 SPH, so that's streptomycin, PAS, INH, and then PH, PAS, INH for 18 months. Whereas if you compare it to the Korean study over here, well, that's six months of isoniazid and rifampicin. And then if you look over here in Korea in 1965, they put a jacket plaster of Paris as well. I think that I'd love to see photos of what that looked like. And then also some of them had, which we'll go into now, I'll go look a little bit more into these, but some of them had surgery involved with them, others just had chemotherapy given. And as you can see, the numbers are quite small. And I can understand it's not something that we see that commonly. I think we do see it here, and that's because we also get the referrals to the center over here. But it's not a really that common problem. And then let's look at the last 3 studies. So the ones done in Hong Kong, Madras, and Korea. And if you look at Hong Kong, they did 6HRS, so that's isoniazid, rifampicin, and streptomycin, with surgery versus 9 months of the same. And really the outcomes, the favorable outcomes were pretty much the same between the two. And then if you look at Madras, radical, so radical means surgical, and A and B is ambulatory, so that's ambulatory chemotherapy. So surgery, no surgery. And not too much of a difference between those arms, and they thought that there was not really much of significance whether you had chemotherapy for 9 or for 6. However, if you look at the Korean study over here, you can see there was quite a marked difference between 9PEH, so that's PAS, ethionamide, and INH, compared to 18 months of the same combination, where it was 90% over there versus 73. And I suspect that might be because there's no rifampicin or PZA given to those regimens. Okay, so now what's the way forward? I mean, these patients are incredibly difficult to monitor response. I mean, actually, most TB patients would just say, how are you feeling? Good, I'm doing better. Okay, weight's going up, night sweats have gone down, cough's got down. So that's quite easy to do, and following up on cultures if possible. But what about doing a FDG PET-CT? And that basically looks at monitoring of uptake of glucose into the white cells when there's inflammation of TB. So that is a possibility. Let me show you a study which I think was done, if I'm not mistaken, on the other side of the Liesberg River, and that's quite a recent study. They looked at 28 patients with TB spine, and they gave them all more than 9 months of treatment, and they included their population was both HIV positive, HIV negative, and they basically wanted to predict the metabolic activity of bone, and they looked at two components to this. So they looking at the FDG PET-CT, but they also looked at biomarkers. Okay, and I don't know what all of these biomarkers stand for. Some of them are cytokines, who knows? I think from a population point of view, rather difficult to do this in our setting unless it's in a research setting. But what was quite nice about it is that people are thinking ahead of trying to figure out what are the best ways to try and monitor treatment duration for them. And I think this might be something that we should be looking at in the near future. And then, as we were saying earlier, ESR is not a great test to be done in HIV populations. Okay, and then there was another study by Duraj, and they basically, same story, looked at this FDG PET-CT again as a imaging biomarker in a prospective clinical observation study. And all 33 of their patients had biological radiological findings in keeping of spinal TB. And their regimen, I find quite interesting. I'm not sure why they went like this, but anyway, they went for 4 months, then rifampicin, isoniazid, and ethambutol for 4 months, and then rifampicin, isoniazid for 4 months. So 12 months all in all. And they basically looked at this standardized uptake value. I called Stuart Moore this morning and I was like, listen, man, I don't understand SUV. All I know is sports utility vehicle. I don't know what this is. So he says to me, Tari, don't even bother telling him about this. We even get confused. Okay. He said, but just essentially, what you can see into this is that the SUV is, in the beginning, will be high. It's the uptake. And then what you see is hopefully by the end of treatment, it goes to a much lower level. And basically what you need to take into account, there's a lot of other factors. I mean, he told me it's like 3 other SUVs that they look at, but by looking at the amount of metabolic activity, you can try and, with a clinical interpretation and looking at other images as well, try to determine that yes, an FDG PET-CT might be a good idea to follow up these patients. And it is something that hopefully will be done in the near future. Okay, so I think some stuff in conclusion is the treatment regimen. I mean, for our TB patients, we usually go rifa for RNZE for 2 months, and then we go into continuation phase of rifampicin and isoniazid for another 4 months. And from what I've read from the data, especially from that Fox article, is that PZA ethambutol in the continuation phase, I'm not too sure how much added value it will give us. And then we really need more studies with regards to duration of treatment. There's just not enough in the literature. And then I think what's exciting for Kurtski is that hopefully we'll be getting our own PET-CT apparently next year. And maybe this will be something that we can actually look into prospectively and trying to have our own population, our own subset of patients with TB spine, where we can look in and see if we can follow them up and have our own data from here.
I'll ask a question.
Yes.
One slightly facetious one. The one point I remember from our last meeting is that I asked about bacteriostatic and bactericidal, and said that's gone. Then your first slide is you're talking about sterilization. It's just confusing, but I don't expect your answer. Just the PET-CT, said that Johan Davis says the spine surgeon Heidelberg that did the PET-CT. I don't understand why PET-CT would show active TB. I mean, it's FDG. It's meant to be for cancer metabolism. I understand that. So why would TB be indicated on a PET scan, firstly? And then if you do, I mean, we seem to be quite confident we get rid of the sort of easy bacteria, but there's all intracellular lurkers that creep back when you're not looking. How's the PET-CT going to pick those up?
Yeah, thanks.
So you're getting a 21,000 rand investigation. There's a PET-CT. This is a private practice, 21,000 rand PET-CT.
Sure. Is it cheaper than an MRI? Is it more
No, it's
expensive?
more expensive than MRI. The whole body MRI is about the same with it, but a PET-CT is 21K.
Yeah, it's a lot. Yeah, thanks. So bacteriostatic, bactericidal, we have moved away from using that, but I'm not sure in the TB literature if we have moved.
This is in bacteria, in normal bacteria. We're not talking about mycobacteria.
Yeah.
It's a different issue.
Yeah.
That was relating to into non-mycobacterial bacteria.
Okay.
And then with regards to, so my understanding is that when you've got metabolically active bacilli in tissue, they consume glucose.
Not the bacilli, sorry.
It's not bacilli.
No, PET-CT has nothing to do with TB.
Yeah.
Okay, yes, I mean, it can be any infection, any inflammatory process. It detects inflammation, right? Or metabolically active tissues. And in the case of TB, that's inflammation.
Is it inflammation? Because I thought it was specifically for tumor metabolism.
No, it's been demonstrated in pulmonary TB very clearly that it's related to ongoing inflammation. And there's even a transcriptomic signature associated with it. So it's not going to tell you whether you've cured TB. It's actually not a great biomarker for that. People have looked at it very carefully, even for treatment short. Implication that doesn't get the predict trial hasn't reported yet, but I know the results of that isn't going to work. But I mean, I think it is a biomarker. It's part of like a tool set that could be used, and I think I agree with Tari. I think it should be studied in this indication because it's so difficult to understand.
In a particular study, they actually biopsied the patient, the first CT first, and then biopsied them, and about 21 of them were positive gene expert culture, so it wasn't that specific anyway.
No, it completely lacks specificity because I mean it's not related to TB.
I mean, the only question I think is whether it's of any benefit in follow-up. But I don't think that, I mean, yeah.
So they use exclusively to check if patients who are on prolonged treatment that reactivate or you know,
the key question for this tool is, does it predict relapse, right? I mean, can you say that at some threshold you can stop treatments, and at that threshold there's a low risk of relapse if you do stop treatments? And that would be the research question. I mean, what I meant is that in pulmonary TB, it doesn't seem to work for that.
Sorry. Just going to ask a question whether we can get back to the issue of duration. Well, I think what Tari's shown, what we understand is that the 4 drugs, ethambutol and pyrazinamide in particular, like ethambutol in particular, is very useful, both very useful in the first couple of months. And there's also, as Tari mentioned, to reduce, to protect rifampicin in particular, so that in terms of resistance. So, the actual rationale for prolonging to 6 months, I don't think is there. Now, your question is, well, what about these difficult to get to bacteria and mycobacteria? And I think that's again comes back to Sean's question about, which is critical, which is the PK at the tissue site and trying to understand that. But my other question is, I mean, in South Africa, you guys are obviously world experts in spinal TB and in the numbers. Isn't it possible to do a 6 versus 9 months, or a 6 month of Regimen versus 6 months of 2 months Regimen 4 months?
Yeah, look, I mean, you can do this study. I mean, you can argue about the ethics about it, but I'm sure you can get past that. But it's really, how do you detect the recurrence? What's the period of time you allow for the recurrence? And I mean, I've got those in my head, and I used to talk every time I go overseas. I think of Graham Mankey's slides of the non-HIV patient that's got a 7% lifetime chance of pulmonary reactivation, and then with HIV, I think it's 7% per annum, So, and that's in pulmonary. The problem with the spine, it can start and this takes so long. It's not infrequent you go back to remove the instrumentation because it's bothering the patient. You find a little bit of pus there, even though the patient is totally asymptomatic, they seem to have controlled the disease. So that's a problem. How long? You'd have probably do a 10-year study to do
I appreciate what's being asked, but I mean, I'm not. The thing is that, as you mentioned, the bias that's inherited in your expert opinion because of the people you see coming back and not.
Absolutely.
I mean,
that's what we need to do the power calculation, how many patients you are.
I mean, I don't think
even for South Africa, you need such a big number of patients to make the difference.
And India as well.
So it will have to be multi-center, probably not just South Africa, and we'll need a massive amount of funding. But it's definitely we should do it. I mean,
the problem is, like, from a clinical point of view, we see the patients clinically getting better over that 9 months. But of course, we don't understand, is it the drugs that are making a difference in that last 3 months, or is this the disease, the patient getting better? But there's no doubt that patients continue to improve over that whole cycle.
But again, there's an issue of, I mean, we're not comparing our apples and apples, we're comparing oranges and apples, but you're also aware now of a number of studies that show that despite ongoing signs of inflammation and infection markers, shorter periods of antibiotics actually have the same clinical outcome. I'm thinking now of intra-abdominal infection where you've got primary source control showing 4 days is absolutely no difference in clinical outcome to 10 days. And even when in 4 days they still had a raised CRP and temperature and a high white count.
Yeah.
So, we've also got to come back to the question of what we're asking those antimicrobials to do and how much, TB is an immunopathological disease, far better than why. But I mean, that's the issue. What are those antimicrobials doing? And how long do you need to continue for?
And would you differentiate between your adjuvant therapy? Because in my mind, that's the other thing. So some patients will come to us, we don't operate. The only operation is diagnostic. So we're not debriding the tissue. There's a higher, we've shown that in that Chinese study that the sclerotic bone, so there's still sclerotic bone as opposed to somebody you've aggressively debrided. Your penetration is probably better because you haven't got that sac of pus anymore. So that's my feeling, anecdotal, well, I don't know, just intuitively, that if you don't operate, you need a longer period of therapy. If I debride it and it's basically just going to pick up a few of those scattered cells, it needs less time,
You could say the same, you could turn it the other way around, say if you debride and really do that well, do you only need too much therapy? Yeah. Because I mean, that's the other study, again, is to look more deeply at surgery plus antimicrobials versus antimicrobials. Yeah. And I appreciate all the difficulties around surgery and the complication potential and time and effort and everything. But I mean, that's the other thing that probably we know that if you source control, your outcomes are generally better in any infection. Doesn't matter if it's TB or whatever.
I want to ask the chapters that you showed where they compared the resolution of the different drug regimes. How did they measure the resolution? Because that's one of the most difficult things is to know when is it gone? Or how did they measure the resolution in those factors?
I think it was based on clinically and radiologically.
That's the favorable outcome that you report today. Yeah.
But you can also, I mean, surely we never eradicate TB, you just control. And I mean, there must be one mycobacterium left there somewhere. It's just that the person then suppresses that. Because I mean, a lot of TB is actually almost in my mind like an autoimmune disease. It stimulates the body to destroy itself. I mean, that's what we see in the spine. This granuloma is destroying everything. It's not really the TB, eating the vertebra away, so to speak. So, I mean, what's actually happening there? Why do some people reactivate and some don't reactivate?
The objective of TB treatment is what's called sterilizing cure, right? I mean, the assumption is that you are actually achieving sterilizing cure. And I'm talking about pulmonary TB because most of the relapses, what you were mentioning was lifetime risk of TB. Yeah. But most of the relapses occur, at least in pulmonary TB, within a year. And the vast majority of those are in 6 months. So if you were to design a trial, which I don't think is feasible in this condition, it's just, I think the numbers aren't big enough. I mean, you would follow up, I think, for 12 months, and I think that would give you a lot of confidence. But this would be answered, at least not answered, but strongly informed, I think, by a prospective study. You could just see your patients, do multiple, because they're going to do multiple interventions depending on the clinical situation, collect information, including PK, and try and find patient-level factors that can predict relapse. So, just get a cohort of people together and follow them for a long time. And I think that will inform this deeply. The trial, I mean, the relapse rates are probably going to be 10%. It's not going to be that high, actually, if you give people 9 months or 6 months of treatment, I don't think. And to show non-equivalent, I mean, to show non-inferiority between two approaches, you need 1,000 patients.
Yeah, but look, I'm not a statistician, I'm not a trial expert either, but I mean, the whole issue of trials has moved forward and the potential for using different methodology to perhaps answer these difficult questions, that would need to be talked about.
Maybe Digital Pcr can be a biomarker.
I wonder, I mean, there are quite a few people joining the meeting from afar, and some, Eunice and others have a lot of experience in treating TB. I just wondered whether anybody else also had a comment. I mean, Eunice, I don't know if if you could give us some idea of how you go about this question in KZN, what the approach is.
Thanks, Marc. Yeah, actually, the orthopods do exactly what your orthopods in Cape Town do. They treat for RIFA for 6 to 9 months, and and my feelings are aligned with the ID department in Cape Town. That really 6 months of treatment should be adequate, with 2 months of intensive phase and 4 months of continuation phase. And the fact that this is a paucibacillary disease, my feeling is that we probably have eliminated the organism, and all we're looking at is the resolution of the inflammation, and we want to be sure that there isn't a recurrence. I had a question for the presentation about the German patient. I was wondering, when the sample was taken at surgery, was it sent for culture, and did they find any TB in the culture?
Yes, it was positive both times.
Okay, so that means that the decision to prolong TB treatment was actually a good idea. So that might be an instructive case that despite prolonged treatment, there was still positive culture, which means that I need to rethink about how I'm seeing this disease.
Yeah, see, but the physician involved, they're diagnosed as a rapid rifampicin metabolizer. They felt for the dose she was on, her blood levels were too low, and so they added more rifampicin. Yeah, you're shaking your head. You want to
Yeah, but then again, you know, we assume that the dose we use in all patients should be equal, and we don't individualize treatment. So it might be, I might need to rethink about the duration of treatment in spinal TB, because I belong to the group the way I believe that you know, whatever we do for pulmonary TB should be adequate for spinal TB, but clearly that might not be the case. So the study that Marc suggested would actually be an excellent study. I know it's a bit of a difficult study to do, and how do you decide if somebody has got ongoing TB once you have stopped treatment is challenging, but I think it's still worthwhile doing. Thank you for allowing me to comment.
Thanks, Ines.
I wanted to ask about that case because I recently had a case in private. We don't use it often, but the oral anti-traumatic agents that's commonly used in pillows like Xarelto, there's a big drug interaction with rifampicin. And it's contraindicated to use it together. So, and it's commonly used in orthopedic patients in private instead of oral agents. So is that something to take into consideration?
Yeah, there's an interaction between rifampicin and rivaroxaban. I think that's what you're talking about.
Yes.
Right? It can probably be overcome by doubling the dose, but you can't monitor rivaroxaban. So just change the patient to another rifamycin like for beauty.
So what do you guys propose? Do you think that there's enough evidence that we should just go on to standard pulmonary TB, 2 months of intensive phase, 4 months of continuation, or what's
Yeah, yeah. I mean, look, I'm on that side of the fence. Yeah, I think so. But I mean, I think Sean's point about prospectively, you know, monitoring and following up. I mean, the question is how long do you do it? But you know, the other issue is that people do get TB again. You know, it's not just a reactivation issue; it's potentially a reinfection issue. Of course, that's pulmonary TB is probably more likely to come into play there. But if it disseminates and there's an area, you know, of potentially that is at risk, like a previously infected area in the spine, who knows? I don't know the answer to that. But I have gone much more towards everybody getting 2 months and 4 months, 6 month course. Because remember, it's not just orthopedic, it's, you know, the abdominal TB, CNS TB, a lot of other TB is treated for longer, based on often on historic issues.
I think more people than we think are de-escalated anyway, because we don't follow everyone up when people go to the clinic. We think they're getting numbed before, but a lot of them at the clinic are going over to the maintenance phase anyway.
Sure. But you don't know what happens to them, they don't all die.
If you look back, I mean, if you've got some registry of this, I mean, I'm sure you guys have recorded all of your spinal TB cases, just like, you know, an MMed student to go and just track the outcomes of all of them, how much TB treatment they got, so just describe that. I mean, you might find that, you know, most of them got 6 months and did well.
Yeah.
I mean, my view on this question.
To the clinic records to see what they are.
Yeah. I mean, you know, it's not perfect.
Well, like a PhD.
But I mean, my view on this is that I think I definitely think that pyrazinamide and inflammasome should be stopped after 2 months. I don't think it adds any additional activity or benefits. And then I would suggest that the duration is 6 to 12 months based on clinical response. And, you know, patients who you feel using whatever metrics you use are not responding well, just prolong.
But still, just 2 months of propofol.
Yes, still 2 months.
But that's still the question, Sean. What defines that?
No, but that's it. You know, we don't know, right? I mean, we don't know, and but I mean, these guys know in their hearts.
We've seen evidence of it. We know that they're caring. But that's the crux of it, isn't it? if our colleagues say they're not doing well, is that because they got infection or is it because of the inflammatory issue? And, you know, each one is different. What was their starting point versus, you know, I mean, it's really tough, but my feeling is that, you know, this is an is one of the great immunopathological diseases. You got what happens with the bug and what happens with the immune system. And the bug is the one you want to get rid of relatively quickly, which you're going to do within 6 months of treatment. I don't believe that it's going to increase recurrence of the disease.
We do this for CNS TB and TB adenitis all the time, right? I mean, we make a judgment and think, okay, well, let's extend the treatment. And that's what I'm suggesting.
Yeah, TB adenitis usually, I mean, I've not used more than 6 months for
These
TB
are hard
adenitis for years.
Yeah.
CNS TB is much more difficult, particularly because it seems with tuberculosis, for example, you know, things wax and wane.
Yeah.
And each individual patient is actually individual, you know, because so some you'll have space occupied lesions and you'll treat, and after 6 months, scans are absolutely normal, absolutely fine. You may come back, you know, and within that also you may have patients who they'll go at 2 months and then at 6 months they'll be back and go, even though they're on treatment, even though their drug levels are fine. So it really is a complex issue.
Yeah.
But I agree with Sean, definitely 2 months of 4 drugs. And then the duration, I would go for 6 months.
I just want to add something from the pediatric point of view, so I know one of the people working at the stuff interested in. And well, firstly, our patient cohort is slightly different to the spine cohort in the sense that we have very little HIV co-infection. In fact, in the most recent write-up, I had 0. So ESR is used as reliable in our setting, and just anecdotally, after 3 months of TB treatment, ESR is usually below 10. So that's one point. And then the other thing I wanted to say is in terms of evaluating the efficacy of 6 months versus 9 months and de-escalation, we already have data for 9 months. So we don't need to do a comparative trial. So for instance, if we agree with you, then I must say the evidence, what little evidence there is a little bit convincing. You're telling me that Regimen and the stops working after 2 months, it stops adding benefit after 2 months, and then why on earth are we going on with it? And that seems to be more scientific than our anecdotal evidence of carrying on with it forever. So if we just make the agreement or agree between myself and Stuart that, okay, cool, let's try this, see if it works, and then you can compare it to our existing data. And I mean, so we already have control, so we just need to
no doubt the place to do it is here, you know, and so our center, and that's where to say we might not need a prospective RCT to get a fairly good answer.
We can do a historical cohort. This is a prospective cohort. I mean, it just makes the action.
Super scholars hand up.
Sipo, you're going to give a comment?
Yeah, no, thanks. And thanks very much. Look, it's very interesting discussion and topic. And mine, I'm more with the orthopedic surgeons on this issue. Just because, look, I think it's biased. One, because these are the patients I tend to see and we probably co-manage with the orthopedic surgeons. I think the issue really is that it's the site of disease. So these individuals have spinal disease. You've only got one opportunity to really get it right. And it's incredibly difficult to treat these patients because one of the things you're trying to do is return them back to functionality. I mean, I think the reduction to 9 months is good, and I think the experience is that seems to work very well. The issue about intensive phase of 2 months, or even extending that to say 4 months of intensive phase and then 3 months of continuation phase, is probably something that also needs to be discussed and looked at. And I think you know, it is very challenging because, you know, spinal TB and tuberculosis are conditions that are heavily neglected. There isn't enough data to tell us exactly what to do. And often what we're left with is people's experience on the ground. And there are some patients who probably 2 months of intensive phase is fair. And I think what probably is fair is those who've had surgery in terms of removal of most of the abscesses. Probably you could do the 2 months intensive phase and then the standard 2 months intensive phase and continuation phase of 4 months. But those where you've just biopsied and left a lot of sort of granulomatous tissue behind, I think needs real thinking about how you manage those patients, given that if you get it wrong, you're going to be left with somebody who can't be functional again. That's just my 2 cents.